So, hi everyone, the class of 2023. So, this is the second part of the series of lecture in laboratory procedures and insertion protocols in RPD, which is the final lecture. So, in the part one, we covered all the laboratory steps essential in the fabrication of a CPD framework, starting from surveying and ending in casting and finishing of a CPD framework. So moving on, as before, the learning outcomes remain the same. You should be able to plan the sequence of laboratory steps involved in the fabrication of a CPD. You should be able to recall the step-by-step procedures involved in the insertion of a CPD in the mouth. You should also be able to appropriately explain the post-insertion care to the patient receiving the CPD denture, and you should summarize the post-insertion dental problems and their management. So, the steps in fitting of the CPD framework are: first, we examine the CPD framework. We examine the CPD framework, whether it is cast properly, are there any nodules, any fins, any roughnesses on the CPD framework, the fitting of the framework to the adjacent supporting hard tissue and the soft tissue is examined first on the duplicated master cast. Then it is articulated and seen whether it is interfering with the opposing or the antagonist occlusion, followed by finishing and polish. So, first, the CPD framework is examined as I told on the duplicated mastercard. That is why duplication of the mastercard after surveying and designing is very important. So here we see what we call a CPD framework for a Kennedy's class 2 situation for the maxilla and the mandible with a modification space over here. It is first fixed on the model, check for intimate fit of the major connector, the minor connector, and the rest seats or rests on the rest seats on the model, and they should be flush against the tooth surface and the tissue. The things that need to be checked are the rigidity and the placement of the major connector on the palate or on the lingual mucosa. We should also check whether all the receipt preparations have been included and the rests are sitting flush without any gaps. Otherwise, it will lead to recurrent caries or secondary decay on the mouth preparation that has been done in the patient's mouth. We should also check that the clasp assemblies are all fitting properly and the clasp tips are engaging the undercuts they are meant to. So after the fitting of the framework is done in the patient's mouth, so we have to check for intimate fit of the rests, the reciprocal arm, the clasp assemblies, the major connectors in the patient's mouth, and relieve any interferences and any painful sharp pressure points. So once this is done, the fitting of the framework in the patient's mouth, we move to the next step. So, before we move on to the next step, the fitting of the framework in the patient's mouth is usually done using a disclosing media such as a disclosing mouth temperature wax or a disclosing pressure indicating spray, which is more easier to use. So, we coat it on the integral surface of the processes being fit in the mouth, and then it is placed in the patient's mouth. Pressure is applied, patient is told to bite in the normal maximum intercuspation, and any pressure points such as you can see over here, the disclosing paste or the spray is not visible in this area. So these are the interferences that need to be corrected or relieved. So, like I mentioned, disclosing wax, usually these are mouth temperature waxes with at mouth temperature melt and flow in the patient's mouth upon pressure. And because they have thixotropic properties, this is the pressure indicating wax, this is the pressure indicating paste. Just like in a complete denture, they are applied with a brush or a cotton bud and placed in the patient's mouth. So after this, the finishing, that is the final finishing of the framework is done. First, the finishing is done with the tungsten carbide burrs, followed by finishing with pink and green stones to give a satin finish. And then the final finishing is done with rubber points. So, so here we see different color coded silicone rubber points. Black rubber point is used for gloss finishing, green silicone is used for fine finishing, and the black bristle brush along with the polishing cake is used for the final finishing, which is then buffed to a high shine. So this is a finished CPD framework. Uh, so this is how a finished and polished CPD framework looks like. So here we can see that the minor characters, that is the lattice framework, the saddle area which will hold the acrylic is not finished. It has a rough sandblasted appearance which needs to be maintained so that the denture base resin will have a good retention to it. Other areas are all buffed to a glossy shine. So a fitting of the framework of the is also done to the opposing dentition to know that the patient is able to bite properly in centric. In any main RPD we don't have centric, in maximum tuck aspiration and in eccentric closures. So this has to be done after the finishing of the framework one final time. And once the denture is inserted in the patient's mouth, the following post-insertion cases are very important. The patient should be told that it will take time for him to become comfortable. It is not a overnight thing or instantly he'll become comfortable to it. Home care, brushing of the new dentures alone will not clean the process completely. He needs to use auxiliary or adjunct products for maintenance of the cleanliness of his oral cavity and the CPD. When the denture past denture is placed in the patient's mouth, it should seat patient should seat it with proper finger pressure firmly, and he should avoid butting into places because this may cause clasp and precision attachment to break. Denture patient should be explained that dentures should not be worn continuously for 24 hours. He should remove his dentures during the night and keep them in potable water throughout the night or when he is not wearing them. Some irritation, sore spot, ulceration under the CPD framework and database is expected and will be adjusted at a scheduled appointment post 24 or 48 hours. So these are the cleaning products that the patient should use. A denture cleaning paste, just like toothpaste, to clean the denture, and denture cleaning tablets, which are used to clean the dentures by putting the denture in the water, and a tablet is put into the water in which the denture are placed. Usually, keeping the dentures in this denture cleansing solution for 20 to 30 minutes is sufficient. Patient should be advised not to leave the denture overnight in these this denture cleansing solution because they may bleach the color of the pink acrylic. So these are basically sodium perborate tablets. They create a highly alkaline environment and which kills all the bacteria and the viruses that may harbor onto the denture patient's cast partial denture. So, in case these tablets are not available, patient can also use vinegar and a tablespoon of baking soda for cleaning the dentures once a week. So, after post insertion, the problems arise. So, all the patients that receive removed partial denture and CDs should be seen within 24 to 48 hours after insertion. If potential problems are detected, they should be corrected at the earliest. Otherwise, the patient will not be comfortable and he may not wear the denture. If there are any problems, patient should be reassured that the problems can be solved rapidly, and this happens with almost all of the patients, and it is to be expected. So usually patients will have complaints like pain and soreness over the ridges because sometimes they may have knife-edge ridges, sometimes they may have tori, exostosis, bony spicules, which if not removed earlier will cause pain, ulceration, also and some undercuts in the areas of the vestibule, and these may cause soreness, ulceration, and other things like instability of the denture. Patient may experience tongue biting or cheek biting. This cheek biting usually happens when there is no overlap between the posterior teeth. That is, just like anterior teeth have a overjet, same way, there should be proper overjet between the mandibular and the maxillary posterior teeth. If they are edge to edge, or if there is an open bite between the posterior teeth, this will cause the cheek to get trapped between mastication or speech and cause cheek biting. So this can be adjusted by again regaining the overjet. If there is no overjet or overlap of the posterior teeth over each other. Speech difficulties usually arise if especially in Kennedy's class 4 situation, if the teeth were placed too palatally or too lingually. This prevents the tongue from pronouncing certain words like sh, ch, and j. And also, patient may have eating difficulties if the denture teeth are not in proper maximal anticipation or occlusion with the opposing dentition. This may be due to occlusal prematurities, which should be adjusted in the patient's mouth using articulating paper or articulating foil, and this should take care of most of the problems. Other problems that patient may have are overextension of the denture flanges, just like you have incomplete denture. So border extension should be properly evaluated. Relief should be provided for the label frenum, the buccal frenums, and the posterior parietal seal. Just like in complete dentures, the posterior parietal seal area should be identified, marked, and the posterior border of the denture should be adjusted. So that's it. This brings us to the end of this part two of this presentation. So this is the reading list. Please kindly go through it. Thank you.